And now I will continue with the virtual emergency department with the team here from Australia. So, Denise, where are you?
I'm here, Chris. Hi, how are you? Welcome from Australia. It's 10:30 here. Singapore's just getting up. Europe's well and truly in bed. It must be late for you, Chris. And I think my colleagues in California would just be getting to the end of the workday. So it's really great to be here today to talk with my colleagues about a virtual emergency department. Thank you, Chris. I'd like to first of all take the opportunity to welcome my colleagues Darren Daff, who is a nurse director at the Virtual Care Service, and Mark Morfitt, who is the clinician lead there. Thank you so much for joining us today, and welcome. Just to start off, I think we all know that virtual care accelerated so much during COVID, and sometimes you need a crisis for things to really move ahead. And I know now that most of the consultations that I have with my doctor are not face to face in person anymore. But I think this concept of a virtual emergency department is a little more unique. And I thought we might start the session with a little animation that you created in the service to tell our audience a little more. So over to you, Matt, to pop that video on.
Welcome to SA Virtual Care Service, improving access and quality of healthcare across South Australia. Patient-centred technology is leading the way for healthcare in South Australia, and the SA Virtual Care Service is at the forefront of this, giving direct access to senior clinicians, nurses, paramedics and specialists, providing urgent care for patients in real time when they need it the most. Providing safe, accessible and efficient healthcare inside a home or community, outside of a hospital setting. It's the same comprehensive care as in an emergency department, but using the latest in virtual healthcare to bring our service to you wherever you need us, with the support of an on-scene paramedic, regional GP, nurse or others in your care team, enabling more people better access to the most appropriate emergency healthcare, fast treatment and fast recovery. Access to the SA Virtual Care Service is simple. When an incident occurs, your first responder or care team will make contact with us via a direct, secure connection. Our team of senior doctors, nurses and paramedics then lead the care process, determining the most appropriate treatment, including initial assessment, thorough consultation and post-discharge care coordination. We can also coordinate prescriptions, referrals and, if required, hospital admission or transfers, providing the best treatment and caring for the needs, preferences and condition of the patient. Most patients referred to SA Virtual Care Service avoid hospital admission, receiving individualised care without leaving home, or through appropriate services within their community. During an assessment, if a patient requires hospital admission, they can be admitted directly with a care plan already put in place by a senior medical team to minimise delay in receiving the care you need. Through the SA Virtual Care Service, first responders, regional and rural hospitals and facility care teams now have even more tools and support to provide patients quicker access to emergency healthcare anywhere you are. SA Virtual Care Service, bringing emergency care to South Australians where you need us. More information is available on our website.
So that's a bit of an introduction to the service. Mark, I wondered if you would talk a little bit about the virtual ED. What problem are we trying to solve? What value is the service trying to create?
Yeah, very happy to, Denise. Look, I think whilst we are probably all a little sick about hearing from COVID, it was an accelerator. And whilst there had been previous work done on virtual models in the pre-hospital setting and virtual models in emergency care across the globe, they hadn't been sort of widely adopted. And we were left with, really, in Australia, most of our acute and emergency healthcare was delivered the same way it was delivered 20 years ago. So there was this real drive throughout COVID to actually work to decrease risk to patients and staff, and look at ways in which we can provide more patient or consumer-oriented care that's sort of based, that's values based, but actually not just in terms of economics, but in terms of what's right for each and individual consumer. And we're using, technology that's widely available, that we're all familiar with, to actually reach in to meet consumers, patients in our community, and come up with pathways to care for them in a way that, frankly, protects them in some ways, protects an overwhelmed system, and is really not only accessible but acceptable to patients. Patients really love it.
Thanks, Mark. I'm going to just share my screen here because we've got a few slides that we might use to support us a little bit today. Sorry, that's a little clunky. One of the things that I'm wondering about Darren, in terms of the virtual ED, we certainly know in our Australian system that patients wait a long time to be seen. How is that translated in terms of the virtual ED? What have you been able to achieve in comparison?
Yeah, thanks, Denise. Certainly, presenting to a bricks and mortar emergency department in South Australia at the moment is, and unless you're having, something immediately life or limb threatening, is going to take quite a bit of time to be seen. So it is not uncommon for patients to be actually parked in the back of an ambulance for a number of hours before they're even able to make it into the emergency department, which is that's not good care at all, but it's a reflection of where we're at the moment in terms of demand. From a virtual care perspective, what we're actually able to do is answer a call within a couple of minutes. We're able to connect our patients through to a senior doctor within generally about 15 minutes, and then a plan of care completed and able to be implemented at about 35 minutes is our median time at the moment. So for most of the or many of the patients that call through to us, we'll actually have a care plan and implemented and able to be actioned before they've even arrived at an ambulance to start waiting for what could be many hours in a hospital. So quite a significant improvement.
Thanks, Darren. I think, having spent quite a lot of time doing observations in emergency departments, and for most of us too, we've experienced that as patients as well. It often just seems a long time till you get to see that doctor who makes decisions.
Yes.
And I wonder, from your perspective, Mark, what you see the difference there, and how that has been received by patients with the virtual care service.
Look, I think it's clearly one of the areas that we've strived to develop, that we've worked on with clinicians that we work with to support patients, but also with patients directly in a sort of a co-design process. And the result of having a system, the system that we have, is with those short waits for senior decision makers, senior clinical decision makers to be involved, is that patients, they sort of bypass a lot of waste, essentially, a lot of non-value adding time for them in their care, and they're not only that, but they're able to receive that care obviously in the comfort of their own home, or wherever they may be. So the value for consumers, and we look at this in terms of net promoter scores from consumers and also the clinicians that we work closely with, is around it's around hearing where they are, what they want, and providing really tailored care. One of the problems we have in healthcare can be that we apply pathways and protocols, and we don't think of the person who they're designed to actually support and treat. And this really allows us to actually reach into people's homes and to meet them where they are, to provide care where they are, because that, that's individual for each patient. And I think that's one of the really core benefits. From a system benefit point of view, clearly, as Darren spoke about, emergency systems around the world, emergency medical systems are, you don't want to say overwhelmed, but they're certainly stressed. And so we're able to take some patients and relieve the acute stress on our emergency departments for patients who may be able to be managed elsewhere, which allows, the hope and the expectation is that allows those emergency departments to function on the cohort that do have to be there, because clearly some of our patients need to go to bricks and mortar emergency departments. And that's, which in turn has benefits for everybody. So we benefit the one, and we focus on the patients on the center of everything we do. But actually, by doing that, we provide a system benefit as well.
And as you say, many of these patients, before the virtual care service would have ended up in the emergency department, would have ended up with long waits. Many of them would have been admitted and using beds within our system. Especially, our beds are very pressured, and this innovation has been very helpful from that perspective. But how do you manage to keep them at home, Darren? What are the or in their place of residence? I know that's not always home, but how do you manage to keep them there?
Yeah, I think for a reasonable number of our patients, and it's probably around 50%, like through the consultation with the doctor here and some support with the nursing team, we're able to come up with a care plan that actually might be a change of some medication regime and some other things. So maybe managing an infection or some relatively straightforward medical care means that they can stay home with their family and friend, with who they live with. Some of our patients do need some additional support or follow-up. So really what we are doing there is leveraging the availability of existing services. So, there's some priority care centres which need a healthcare professional to refer in, where they patients can have some imaging and see someone face to face for some maybe some more complex wound care or something like that. And there's a few geriatric focused services where we're able to have patients moved to a set space where they can have a full geriatric nursing, medical and allied health review and some imaging if that's required to determine their their status, and then generally those services are same day type services. Within a few hours, wrap that care around and return the person to home if that's appropriate, or facilitating an admission direct to a bed to hospital for those patients where that's required as well. We've got some hospital in the home and my home hospital type services where we can take a virtual inpatient admission for patients, so they can have a daily ward round and a nursing visit for some more advanced therapies if that's required. So, there's a whole host of options available. Up until our service started, really the predominant way to access those services was that you needed to attend a hospital first so that you could be diverted somewhere else where that was appropriate. And so really having a virtual front door to the services is adds some value.
So one of the things I really love, Darren, about this service is how you've extended that value stream into the community, and how many community services and organisations that you deal with. And I know in a little while we're going to talk a little more about the aged care service or residential care, but I think it has been great part of the story about who everyone who's is involved. I'd like to move forward just a little bit and talk a little bit, Mark, about what you've achieved. You've been operating now for nearly 12 months, and I think as we can see there, you're pretty close to your 10,000 calls coming in. Can you tell us about the achievements of the service a little bit?
Absolutely, Denise. Look, I'm really hopeful we're going to hit 10,000 on our first birthday. We're tracking to be within 1 or 2 days of it. So, and for a foundational year, I'm happy with those numbers. I think we've started a journey that will progress and grow. And, we're partnering with a number of different organisations to see how we can deliver, value-based care in a consumer-centric way. You can see on screen, Denise has shared some of our net promoter results. I was really, in fact, the whole team from the start was really focused on making sure that we were safe, obviously, and making sure that we were providing an acceptable option for patients. And we talk about the 6 domains of quality in measuring outcomes and success. We give the vast majority of our patients come from our ambulance staff, our paramedics who call in and want some assistance, and we give so that's the South Australian Ambulance Service down there, or the SAS Net Promoter Score. So we give every paramedic the opportunity to provide a net promoter, and after each encounter with the service. But we also have extended that to direct to our patients. We send out text messages and ask for feedback. And I think that's incredibly important, because at the end of the day, whilst our paramedics are key partners, we're about the patient, and the patient's at the centre of everything we do. We also get some structured feedback where we do extended interviews with patients and their families each month, just to make sure that we can improve where we need to improve. We learn all the time. And we're providing care that's right for people. So in terms of outcome, our state health system is very keen on the fact that about 70% of the patients we see avoid bricks and mortar emergency departments. We like to think we are an emergency department, just a virtual one. So if you like, our political masters like that number. Myself and the clinical team are far more interested in the patient level experience, the clinical outcomes, and the talk that we all have as a leadership group to the new staff who start here is the patient is at the center of everything we do. And if you have a shift and every one of those patients needs to go to emergency because that's the right place for them, and you send them all to the emergency department, then that was a good shift because you've done the right thing. So we really strive, and I think Denise has popped our guiding principles up there, which really, I think, reflect that. And I guess we'll have an opportunity, I think, to talk a little bit more about those. But, we've been able to show in the last almost 12 months that we are safe, effective, accessible and acceptable for patients and for the community at large. So, we're quite proud of that.
Thanks, Mark. And I had the pleasure of, facilitating this session before the service was open, where the leadership team came up with these principles. And I think what has really struck me is that you have continued to live them every day. Often these sorts of things are developed and then they go and sit on a shelf somewhere, but they are really lived on a day-by-day basis within the service. One of them around being agile and trying and learning fast. I remember coming in those early days and taking what you were, you had 8 weeks to get this service up and running, and there were, heaps of challenges around that. But I think your use of visual practice, your use of breaking these tasks down into what needed to get done every day, coming together as a team. And I think, the fact we put it outside the CEO's door so he could see that we're actually making progress every day and didn't come and ask where we were up to with everything was probably pretty helpful as well. But I thought just, going back to the principles, Darren, wondered if there's, any of the other principles you would like to touch on in terms of how the service responds.
Yeah, thanks, Denise. I'm really pleased that you mentioned that the service is living these principles. One of the things that is really really interesting is, as a new team, so not just the leadership team, but the broader clinical team coming together. They really do believe in what we're doing, and using the principles. They actually reflect them in their practice every day, and I think you're absolutely right. These things tend to just become tokens rather than something that people will live by. But the team here really do embrace them. And, you know, when you talk to them, they very much talk about the patient at the centre of their care. They talk about, you know, the pace of change and the improvement aspects of what we're doing here. I think probably, you know, the idea around value, valuing ideas and having waste-free processes are probably, I'll say they're a bit tricky. You know, healthcare is often bound and up in knots with, you know, complexity and inefficiency. And so really, here we've had to be quite deliberate and thoughtful around making sure that as we build and change things, that we don't build in those inefficiencies that we're trying to remove, and, you know, valuing people's ideas and making sure that they, you know, everybody has an opportunity and a process to be able to put their ideas forward has been also really important for us. You know, having people's ideas heard and, you know, using the team from the floor to not only bring those ideas forward, but then the team problem solving time to actually come up with the recommended solutions for the things that are frustrating them in their daily work has been really important for us as well.
Thanks, Darren. And I mean, one of the things that has surprised me is your continued commitment to, you know, understanding the work and understanding what that looks like. And I know that, you know, I used to be a little bit challenging around the way the work was organised, because, you know, some of us might look at this and say, well, it's pretty much how a traditional bricks and mortar ED might flow as well, except we do get to that senior decision maker quite fast. But I've loved the way you've embraced these observations and what you've learnt from them, and your you know, it's not something that you've just done for a day or two. You know, 12 months down the track, you still have standard work around doing these observations and talking about them and learning from them and doing those PDCAs. And I think we've got a little bit of an example of one here that we might talk about that really came from that value stream, where we could see, I'm just going to go back there, we could see that call length there being, you know, 43 minutes, and we've got really just got that one weight in there around the doctor decision and plan. And so we might think, you know, 6.5 minutes isn't very long, but the way that the team has looked at this as a group and thought about how else the work might be done. Just wonder, Mark or Darren, whether you might like to speak to that a little bit.
Oh, look, I'm very happy to. You know, I remember being incredibly challenged when quite early on Denise came to us, and we thought we were being all very clever and setting up this virtual emergencies department. And she walked in, sort of looked at it and said, "Oh, that's nice. You've just recreated what you knew." And it did, and it had the cues that we have. You know, we cue to doctors. So having recognised this and having had members of the improvement team sit down and map what we're doing and identify those cues, which, you know, 6.5 minutes doesn't sound like a lot, but when you're a paramedic with a patient in their home, and that ranges out to 40 plus minutes, that's a lot of time. So we sat down and were able to look at different ways of working. And so Darren is probably a better place to talk to it more, but we essentially, by including our nursing staff on the calls, we're able to show a really significant decrease in total call length. We reduced some waste in terms of unused or recognised staff potential in our nursing staff, although we still have some way to go with that, I'd argue. And we cut our call time down really substantially. And that is, you know, and that's become how we do business now. And it needs, I think Denise made the comment that it's good to come back and see us still doing this, but actually the sustaining part of this has been really important, because people slip back to what they've been familiar with. So really embedding this as practice is something that we have this lovely, fairly small team, and we remind ourselves of when we see it dropping away. I don't know, Darren, if you want to speak to that anymore.
Yeah, look, I think, you know, from a nursing team perspective, one of the challenges with the idea of having the nurse sit in with the medical component of the patient consult was, well, that's just going to take more time. We won't have time to fit it all in. How are we going to make that work? And it was a little bit counterintuitive, I think, for people, to the idea that by spending more time together, we'd actually be able to improve the total length of the call time. But the results absolutely have speak for themselves. And where there are sometimes, if people don't manage to get into the, if the nursing staff don't join the medical call, what we find is that then that we're waiting for the doctor to be able to speak to the nurse to hand over the tasks and the requirements for that individual. So absolutely value adding, and on the few occasions where it does slip, we are very quickly reminded about why it's so important and how it does actually enable us to make a difference. So yeah, I think it's been one of those things. It wasn't necessarily intuitive. Not everybody liked the idea. It was a little bit a bit of hard work to actually convince people that it was the right thing to do. But once we actually crunched the numbers and were able to show the story, I think most people were able to accept that actually, what, maybe we were wrong and we need to do things a little bit differently, and are prepared to keep going with that.
I love this value stream map because so simply it shows that we've maintained the value added time for the patient, but shortened that call length by doctors and nurses working more closely together, and and balancing the work and involving the nurses on now almost 100% of the calls is my understanding, and that's just really great from a team perspective. Mark, I think one of my other observations has been too around the way that the emergency department physicians and the general medicine physicians are working together in the virtual care service as well. Would you like to comment on that?
Yeah, look, absolutely. I think it is one of the strengths. We have a mixed staffing model. So we have emergency physicians, we have some internal medicine physicians, or we would call them general physicians, and we have also some originally based general practitioners or family physicians if you're in the States. And we bring them together, and that's something that you don't have so much in a classical medical model. But actually, because if I'm working as an emergency physician and I have a general physician next to me, it actually allows us to bounce to our strengths really quickly, and it builds relationships that I think move not just here, but all of us have part-time work outside of here as well. So we're actually building a changed model, hopefully more widely than just here. So
thanks, Mark. Darren, we can talk a little bit more about this as we're going to go to Gemba in a minute. This sort of first half is a bit of a chat. Second half, we're going to Gemba. But I think, one of the things that has also struck me about the service is that you've had to get really good at creating new stuff. And, we've been using some design thinking, we've been using some LPPD, we've been bringing it together, and I think this is really exciting to develop this capability around developing new services. So I wonder, as we sort of finish off for the interview half, whether you'd like to talk to this a little bit in terms of this work.
Yeah. So when we started, we were primarily accepting referrals from our ambulance service colleagues. So what that required was someone would call 000. They would queue for their ambulance, and then when the ambulance arrived, the paramedics at the scene would make a decision to call us if they thought that we would be able to support a patient without sending them to the emergency department, or they would refer, or just do their normal business and take the patient wherever they thought. Through looking at some of our data, what we identified was about 16% of the calls that we were receiving to virtual care were actually coming from a residential care facility or an aged care home. With those patients, they are staffed areas. There are registered nurses available in those facilities, and we started to have that thought around, why are we making these people call for an ambulance if they don't necessarily know, or they know that they don't necessarily need to go to hospital, but they do need to be able to see a doctor. So what we were able to do, so we held a workshop with just one of our aged care providers and some of our GP friends and some people from our service to really look at, what would it look like to enable the nursing staff from within a residential care facility to call us directly and connect with our nursing and medical staff here in virtual care, rather than waiting for an ambulance to arrive. Noting that some of the, the low acuity ambulance times are are long, like they can be really long waits. So, 6 hours is not uncommon for a low acuity ambulance into residential care, and they can go as long as 24 hours waiting. So if there's if we've got a patient who actually requires care, waiting for up to 24 hours before they're even able to move to hospital just makes no sense. So enabling the aged care facilities to call us directly has provided the opportunity to, intervene faster. What we're seeing is that more of those patients in residential care are actually able to stay at home in their facilities. So for the first 100 calls that we had direct from the residential care facilities, only 8 of those patients moved to hospital. The rest were able to be managed in their homes with the staff that were available to them already. So, relatively small in terms of a change for us, but massive in terms of an outcome for individual patients, but also for the system.
Thanks, Darren. Chris, we're going to transition straight to Gemba, so we don't need you. You can disappear. And I suppose as we do that transition, Darren, like to say thanks to Mark very much for joining us. We haven't talked so much about our learning system, but we knew we'd have time to do that during Gemba. But I think that, that's such a strength of the service, is your commitment to learning and improving every day. And so, I like to take a few risks and see how we go by transitioning to Gemba and go and maybe start with the daily team huddle, which is, really one of the important points of problem solving and learning every day. So thank you, Mark. Thanks so much for being part of this.